Good evening. Good evening and welcome to CV Live. This is our episode 1 on ischemic heart disease. We thank you for joining us today in these very extraordinary times. But I think what better way to learn in today's day and world other than digital media. So again, I got my Purell on and let's talk about the topic today. We shall be talking about when is revascularization appropriate, one of the hottest topics over the last 6 months. And we are trying to go from trials all the way to what the practice should be. Again, I'm Dr. Alpesh Shah, I'm an interventional cardiologist, and welcome again. So I'll start with a case scenario. Let's talk about this very pleasant 74-year-old female who has a history of hypertension, dyslipidemia, type 2 diabetes, on insulin. She has a strong family history of premature coronary artery disease. The patient was seen by one of my colleagues for left arm and substernal discomfort, sometimes exertional, but not always. She underwent a pharmacologic cardiac PET that revealed 11% ischemia in the right coronary artery as well as the LAD territory, but with markedly elevated coronary calcium score above 1,000. She was recommended diagnostic coronary angiography, and then obviously with possible PCI if the right thing to do, given the fact that she has markedly elevated coronary calcium score with her symptoms, especially to rule out significant CAD. So this is what we see. These are injections of the left coronary system, and you can clearly see the LAD has severe disease in the mid portion, and the RCA also has severe disease in the mid portion, but the circumflex is okay. So this is a very classic patient. The patient's symptoms are mild to moderate, but she does have at least a moderate ischemic defect on a nuclear imaging stress test, PET stress test. So then the question is, in stable patients with at least moderate ischemia on a stress test, is there a benefit to adding cardiac catheterization and, if feasible, revascularization to optimal medical therapy? That's a burning question in 21st century as we speak today. Not that this question is that new. I mean, we have talked about this for almost a decade plus. I do want to quickly and briefly highlight 3 trials which have been available to us in the last decade or plus. But as I would call them, the OMT era, where optimal medical therapy, whether statins or DAPT and antianginals, have been very well understood. So these are strategy trials of revascularization in patients with stable ischemic heart disease. One is COURAGE, second is BERRY-2 in diabetics, and obviously FAME-2. So let's start with COURAGE. Very impressive trial which got published in 2003 in New England Journal, more than 10 years ago now, and PCI did not reduce death or MI in patients with stable ischemic heart disease. As you can see in this curve, when those patients were followed up to 6 or 7 years, the event rates between optimal medical therapy as well as invasive approach was no different. However, one must note that almost 33% of those PCIs, 33% of the OMT patients had to go through PCI. So every third patients who were in the medical arm did eventually end up getting a PCI at some point in that study protocol. And also within the PCI group, about 1 out of 5 patients had a repeat PCI in that group. But again, all said and done, the primary endpoint, no difference between optimal medical therapy or an invasive strategy. Again, this is the era where only bare metal stents were mostly used. Just to correct myself, this was published in 2007. But there is a bigger challenge with COURAGE, and that is the challenge of recreating real world into clinical trials. So to enroll about 3,000 patients, which is 3,071 to be precise, they had to screen 35,000 patients. So only 8.6%, only 10 or less percent, 1 out of 10% met the criteria, eligibility criteria for COURAGE. it's also important to understand what were the exclusions. So out of those 32,000 patients who did not meet the criteria, as you can see, about 8,000, out of those 8,000, 5,000 had not enough documentation of ischemia. About 4,000 did not meet the protocol for vessels. About 6,000 for varieties of logistic reasons. But also, almost 18,000, more than half, had some form of exclusions, such as they had undergone a recent revascularization, had an inadequate EF, had a contraindication to PCI, had a serious coexisting illness, had concomitant valvular heart disease, class 4 angina, failure of medical therapy, left main stenosis more than 50%, and the lesion was restenotic lesion, not a de novo lesion, or obviously had complications after MI. So what we got to learn from this sort of trials is that it takes a tremendous amount of effort to weed out the right kind of patient who meets the criteria for such trials, because the vast majority don't. Barry 2D, again the same thing. These patients were followed up to 5 years, and the survival difference between revascularization versus medical therapy, no difference at all. The medical group, the patients who were randomized to medical therapy, there was about 19 to 20% of revascularization at 1 year and 42% by year 5. So there's almost 1 out of 5 patients who's going to require some sort of revascularization strategy within the first year. Very significant. But again, just like Courage, very few patients, almost just 1/3, received drug-eluting stent. And that again being first generation, if you were to believe in the difference. So there are design limitations of trials like Courage and Barry 2D. First and foremost, there are low-risk patients included because the vast majority of any of the high-risk features get excluded, as we just went over the Courage exclusion data. There is a referral bias because the patients are getting randomized after the cath. Sometimes physicians don't want to enroll them. Sometimes patients don't want to join because they know they have this 80% blockage in one of their vessels. But also the revascularization procedures are not optimal in those trials. There was little amount of drug-eluting stent. I mean, in today's world where 90% plus of our PCIs are drug-eluting stents, the question is, are those data valid? No FFR. And obviously in the Courage, there was no bypass surgery. FAME2 was an interesting trial. It got published in 2012, about 8 odd years ago. And it randomized patients to FFR-guided PCI versus medical therapy. Impressively, FFR-guided PCI did significantly better with a p-value of less than 0.001 compared to medical therapy, hazard ratio of 0.3. What is also equally important to note is that FFR-guided PCI did as well as patients who had no flow-limiting stenosis based upon FFR. So tremendous data which actually shows that when you add physiology to anatomy, you definitely can do a much better job at optimal revascularization. And at least in FAME2 population, it outperformed medical therapy at 1 year. But there is a remaining gap. Is there any high risk of stable ischemic heart disease patients in whom revascularization improves death MI in the era of modern medical therapy? Well, there are observational studies which have been done. And these observational studies have shown that revascularization was associated with low risk of cardiac death only in those with more than 10% ischemia on perfusion imaging, as you can see. And there was a Courage sub-study also kind of restating the similar idea that you got to at least have moderate amount of ischemia, more than 10%, that there may be potential benefit of revascularization. So moderate to severe ischemia. So based upon this idea, based upon this hypothesis, based upon the historical perspective, NHLBI funded this huge study called Ischemia. It stands for International Study of Comparative Health Effectiveness with Medical and Invasive Approaches. So we'll go through certain slides, try to understand the process of ischemia trial, patient flow, obviously the outcomes and what it means to us in our day-to-day practice. It was a truly global trial. China, India, Europe, US, Canada, so on and so forth, a truly global trial. This is just a little overview I want you to grasp. So patients, the first initial contact is almost always with a stress test. Whether it's an echo stress test, nuclear stress test, MRI stress test, or EKG treadmill stress test. And that has to confirm moderate to severe ischemia for the patient to even be considered to be part of this trial. Coronary CT angiograms were performed in about 73% of those randomized patients. And once that was done, half of the patients were randomized to conservative arm, which is combination of medications, lifestyle optimization, exercise, do not smoke, so on and so forth. And half of the other patients got randomized to invasive arm. But again, they also got the benefit of medications, lifestyle modification, exercise, and do not smoke. In the conservative approach, if the patient did well and they were satisfied, we deemed them successful throughout the follow-up period of the study. But if there was any failure of therapy there, then they were obviously followed up with an angiogram and then revascularization, whether it's stents or bypass surgery. So this is the patient flow. So let's just go dig a little bit deeper. So let's start with a stable patient, about 8,500 patients. Again, they all have to have moderate to severe ischemia. It is determined by the site, but then the core lab reads it. Now, some of them did not require a coronary CTA because their GFR was between 30 to 60, or they already had previously defined coronary anatomy. But about 73% did get coronary CTA. However, the enrolling site is blinded to that. The coronary CTA was sent to the core lab. The core lab will determine if the anatomy is eligible. Obviously, if it's not eligible, then it will be deemed screen failure. But if the anatomy is eligible, then the patients were eventually randomized. And that led to about 5,179. And half of them went to the invasive arm and half of them went to the medical arm. The design follow-up is out for 5 years. The median follow-up is 3.2 years. And this data, these slides, are borrowed from the presentation at AHA last year in 2019 by Dr. Hockman's group. So what were the eligibility criteria? Again, a lot of these trials, especially on stable ischemic heart disease, it's always about how can we apply this to our clinical practice. So you got to know which patients were included and not included or excluded. So there are certain type clinical and stress test eligibility criteria. So for example, age has to be more than 21 years. There has to be evidence of moderate to severe ischemia, not mild, moderate to severe ischemia. So on a nuclear SPECT, for example, more than 10% LV ischemia with a sum difference score more than 7. On an echo, more than 3 segments, stress-induced moderate to severe hypokinesis or akinesis. On CMR, perfusion, more than 12% of myocardial ischemic and or wall motion with more than 3 out of 16 segments with stress-induced severe hypokinesis or akinesis. On exercise tolerance testing, more than 1.5 millimeter ST depression in more than 2 leads or more than 2 millimeter ST depression in single lead at less than 7 meds. So we can't take patients who walk for 9 meds or 10 meds. And they have to have angina during the stress test. So a little stringent on exercise tolerance stress test. The major exclusion criteria, as I've listed below them, included NYHA class 3 and 4 heart failure, unacceptable angina despite medical therapy, EF less than 35%, ACS within the last 2 months, PCI or CABG within the last year, and eGFR of less than 30 or the patient is on dialysis. Well, they actually created an ischemia CKD sub-study, which is also very interesting, but we'll skip on that today. So there are some patients who went through that. The ischemia eligibility was determined by the sites and all stress tests interpreted by core labs. Now, there are also coronary CTA eligibility criteria, as I said, which was decided by the core lab only. And the inclusion criteria was more than 50% stenosis in a major epicardial vessel in the stress imaging portions, so the nuclear, the echo, and the MR, or more than 70% stenosis in proximal or mid-vessel in the patients who went through ETT, so again, much more stringent, to eliminate some of the false positives, I guess. The major exclusion criteria, again to remember, is that more than 50% stenosis in an unprotected left main. So those patients were excluded. The endpoints, the primary endpoint was a combination of time to CV death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. The major secondary endpoint, time to cardiovascular death of the MI, quality of life, which again comes out as a separate presentation, but I do want to touch on that a little bit later today. The other endpoints included all-cause death, net clinical benefits, stroke added to primary endpoint, and components of primary endpoint. So let's talk about some of the baseline characteristics. The first column talks about the total, all the patients. The one in red is invasive and one in blue is the conservative or the medical therapy group. But reflect on the total, on the baseline characteristics, because there's not a whole lot of difference between the two groups. So age is, median is 64, female representation is 23%, hypertension is 73%, diabetes in 42%. More than our usual trials, I would say. And also relevant because revascularization has a unique challenge, especially in the PCI world. Prior MI 19%, ejection fraction is 60%, systolic blood pressure, diastolic blood pressure. LDL, the mean LDL is 83, median LDL is 83. History of angina is there in 90% of those patients. Angina became more frequent over the last 3 months, was present in about 29%. And the stress test modality, about 75% of them had stress imaging, and the rest, 25%, had a exercise tolerance stress test. I think all said and done, this does represent a typical clinic patient which we all encounter in our practice. Let's look at a little bit more in the stress test as to how did the core lab interpret those data. So again, stress imaging was 75%, exercise tolerance test was in 25% of those patients. Inducible ischemia. So severe ischemia, 53% in the invasive and 55% in the conservative. So the vast majority of the patients had severe ischemia, very impressive. Other 34% and 32% respectively had moderate ischemia. So based upon this, you can say that more than 80%, close to 90% of those patients had moderate to severe ischemia. The rest had either mild or none. What about baseline coronary anatomy? 77% of those patients had multivessel disease. 77%. That's a large amount of patients in this patient. This is not a one vessel disease selected subpopulation. These are patients with more than 2 vessel, and in about 44 to 47%, more than 3 vessel major epicardial coronary artery disease with more than 50% stenosis. In terms of vessels, almost 87% had LAD, 47% had proximal LAD. Circumflex and RCA was present in 60 to 70% of those patients. So let's talk about cardiac catheterization, revascularization. It's very important to understand this. So in the red, you have the invasive approach patients, and in the blue, you have the conservative approach patients. If you follow the red line in the left curve, you can clearly see that 95% of those patients have had cardiac catheterization, or diagnostic cath, so to speak, at the time of enrollment. In the conservative group, about 9% have it at 6 months, and 28%, almost 30%, have it at about 4 years. Well, what were the indications for cath in those conservative group patients? Suspected or confirmed event amounted to about 13%. Non-adherence to medical therapy amounted for about 8%. I mean, a lot of patients don't want to take their beta blockers, do not want to take their isosorbide, so on and so forth. Cost, side effects. OMT failure was deemed to be a reason in about 4% of those patients. So those were the patients who had to be converted to invasive cardiac catheterization approach. On the right, this is PCI, revascularization, PCIN or CABG. And you can see that out of all the patients who underwent cardiac cath, about 76% or 79% at 6 months or 1 year had some form of revascularization done. So not 100%, not 95%. So not everybody who got a cath got revascularized. About 20% odd did not. About 7 to 12% in the conservative group, and about 23% at 4 years in the conservative group did get some form of revascularization. It's very important to understand that, to realize, are we studying revascularization versus optimal medical therapy? Are we studying cardiac catheterization versus medical therapy? What are the modes of revascularization? So the first procedure for those revascularizing, which is about 80%, as I said, it's not 100%. They got revascularized. Out of those 20% who did not get revascularized, it is interesting to understand that 2/3 had either insignificant disease on their coronary angiogram, or the other 1/3 had extensive disease unsuitable for any form of revascularization. PCI was successful with a stent placed in 93%, and 98% of them were drug-eluting stents. And in coronary artery bypass surgery, IM graft was used about 90 to 93%. So let's get to the bottom of this, the ischemia's primary outcome. The primary outcome, which was again defined by cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest, at 6 months, the delta of about 2% favored the conservative arm, and the delta of about, again, 2% at 4 years favored the invasive arm. There's almost a crisscross, as you can clearly see in the blue and the red line here. So there was an initial benefit to the conservative group, and then later some benefit to the invasive group. But again, none of them are significant. The p-value is 0.34 with an adjusted hazard ratio of 0.93. These are some of the primary endpoints in pre-specified important subgroups. I'm not going to go over all of them, but I think there are few which I think we ought to highlight. For example, what about how many vessels are involved? 1, 2, 3. Well, as you can see, there is really no difference between those three groups all said and done. What about patients with proximal LAD? Again, not a big difference. Maybe possibly favoring the PCI group, but can't say that. And the amount of ischemia, again, the smaller the amount of ischemia, maybe it was favoring conservative arm, and the larger amount of ischemia, the severe ischemia, did probably favor PCI. But again, these are hypothesis generating, but pre-specified important subgroups. What about the major secondary endpoints, such as cardiovascular death or MI? I think this is important because it does weed out some of the other noises of unstable angina and heart failure and so on and so forth. Cardiovascular death or MI followed almost an identical curve to the primary endpoint, where the delta was about 2%, favoring conservative therapy at about 6 months, and then the delta was about 2%, favoring the invasive therapy at about 4 years. So again, crisscross, the p-value remains not significant at 0.21 with a hazard ratio, adjusted a hazard ratio of 0.9. Myocardial infarction, MIs, similar wave, similar graph, again a crisscross at about 2.5 years. Again, the p-value is 0.38 and adjusted hazard ratio is 0.92. So we talked about primary endpoint, we talked about death MI and now MI, and really similar pattern emerges in this particular group of patients in this ischemia trial. I think this has gotten a lot of attention. Is myocardial infarction? Let's dig a little bit deeper. The procedural MIs, we will call them type 4 or 5. Procedural MIs, on the left graph you can see, are happening at your index event, which is the revascularization. And then it becomes rather static after that, for obvious reasons. But however, interestingly, there's a late catch-up on the spontaneous MI, type 1 to 4B, 4C. There's a late catch-up. At about 1 year, you start seeing a separation of higher incidences of spontaneous MI in the conservative group. Cardiovascular death, again, does not show any difference with a p-value of 0.33 between the conservative as well as the invasive groups. All-cause death follows a similar trend. The additional endpoints, hospitalization for unstable angina, no difference. Hospitalization for heart failure, no difference. Resuscitated cardiac arrest, no different. Some may call it is very significant, some may think is not relevant. Stroke, again, no difference. So in summary, ischemia leads to certain ideas, certain observations. For example, the curves cross the primary endpoint and the major secondary endpoint at approximately 2 years from randomization. The curves cross, that's the key word. About 2% higher estimated rate with invasive at 6 months and about 2% lower estimated rate with invasive at 4 years. Procedural MIs were increased with an invasive strategy. Spontaneous MIs were reduced with an invasive strategy. Low all-cause mortality in both groups, very low mortality. Despite high-risk clinical characteristics, high-risk ischemia and extensive CAD, go figure. The centers did a very good job and they selected good centers. There is no heterogeneity of treatment effect, including by type of stress test, severity of ischemia, or even extent of CAD. Very low rates of procedure-related stroke and death. So remember that. I want to spend a couple of minutes on the ischemia quality of life QOL study design. This was done as a sub-study, again the same enrollment, patients were followed up at those intervals, and the Seattle Angina Questionnaire with angina frequency, quality of life, physical limitations, which led to a SAQ summary score, which was the primary endpoint, and the others were angina frequency or quality of life were secondary endpoints in this particular study design, QOL study design. I think it's important to know what we are doing to death, what we are doing to MI. That is, I think it's also relevant to know, is there a difference between quality of life? So the baseline health status, this is before we do any randomization. The summary score is 73 in the invasive, conservative is the same. so on and so forth. Really not much of a difference between the two subgroups. About 21% of those patients had daily or weekly angina, which I think is significant. About half, 44%, had several times per month. But there is also a group, about 34%, which almost had no angina. So as you can see in this graph, there is definitely a reduction. The SAQ summary score is better in the patients who underwent invasive approach. And you can see the benefit really early on, as early as 1.5 to 3 months, 30 days onwards, and the benefit persists throughout the entire length of the study. About primary QOL outcome is better in this subgroup. Now, you take all the patients who are typical patient of ischemia. As you can see, there is 3 months, there is 12 months, and 36 months. And in each of their time points, in a typical patient, all ischemia, all comers, you have a benefit of invasive approach at every time and point. If you have a patient who has more angina, daily, weekly, who comes to your office and says, "Doc, I'm having episodes every other day." Again, a clear benefit and a sustained benefit up to 3 years in those patients in terms of their QOL, primary endpoint. In patients who have no angina, there's really no difference. I mean, which is probably not surprising, but you don't see a big change, maybe a slight improvement, because as you know, patients do come and tell you that, "Oh, I feel better." So if I were to come up with the conclusions of both of this, ischemia and QOL, again, today I haven't spoken about CKD subtrial, maybe for another time. So what are the study conclusions? Number one, ischemia is the largest trial so far of an invasive versus conservative strategy for patients with stable ischemic heart disease. Overall, an initial invasive strategy as compared with an initial conservative strategy did not demonstrate a reduced risk over the median of 3.3 years, with the primary endpoint being death, cardiovascular death, MI, hospitalization or unstable angina, heart failure, and resuscitated cardiac arrest. The major secondary endpoints also included CV death or MI. So it's important to remember that there was no reduction of risk with invasive strategy. The probability of at least of a 10% benefit of invasive on all-cause mortality was less than 10% based upon pre-specified Bayesian analysis. Patients with stable CAD and moderate to severe ischemia had significant durable improvements in angina control and quality of life with an invasive strategy if they had angina, which is daily, weekly, or monthly. In patients without angina, an invasive strategy led to minimal symptoms or quality of life benefits as compared to conservative strategy. And in patients with angina, shared decision making should occur to align treatment with patients' goal and preferences. It's very reasonable, because you can clearly tell a patient that if you have significant angina, I think revascularization is definitely going to help you. But ischemia also tells us that probably at least up to the study period, there is no superiority of invasive approach over the conservative approach in the primary endpoints of death, MI, hospitalization for angina, unstable angina, heart failure, or cardiac arrest. So I think those are very, very important points. But there are study limitations, just like all studies do. It's an unblinded trial, so there is no sham procedure. Patient knows, doctor knows. Based upon exclusion criteria, the trial results do not apply to patients with ACS, highly symptomatic patients. Today I had a patient who went to my colleague's clinic saying, "I'm just having tremendous amount of chest pains every time I walk." Well, that patient would not have met the criteria for this study. Left main stenosis or LVF less than 35%. Trial findings may not be generalizable to centers with higher procedural complication rates. The centers which were part of the ischemia trial have just done a stupendous job. Completeness of revascularization has not yet been assessed. We didn't really talk about that. Missing SAQ data, although very small. There is skewed enrollment towards less symptomatic patients. The larger effects in more symptomatic patients, still clearly accessible. Again, a no sham group. However, the angina relief data is not unlike the Orbita data, so we can probably rely that I think they are pretty accurate. Some thoughts. This is applicable to similar patients to those enrolled. I think that is key to this discussion. So who is eligible? There is no evidence that ischemia was relieved. So there was no stress testing done after revascularization or after optimal medical therapy, so we don't really truly know. I think that would have been a very cool study design, probably even more expensive. Coronary CTA preferable to stress testing. And as an invasive cardiologist, a lot of people say, well, is this going to affect the cath lab? Is it going to affect what you do? I actually beg to differ. I think we already, for most part, are already doing a lot of these things because ischemia did confirm what we were already practicing to a certain extent from the Courage days or even the AUC guidelines. But I think what it has done is rekindle the debate between anatomy by coronary CTA or ischemia by stress testing. So is CCTA preferable to stress testing? That's the question. What is the role of surveillance and stress testing? Should we even be doing stress test anymore? I mean, if your primary endpoint shows no benefit, we are still going to recommend patients diet, exercise, medications, so on and so forth. Why even do surveillance stress testing? Go figure. How to evaluate microvascular angina, that's another separate topic. PET would have been very helpful. The invasive relieved angina in 66% who had it. So that's a pretty strong statement. It is not sham controlled. So the patients do know about it. So is it a placebo effect? It could be. Medical therapy achieved in 41% of those cases. So my goodness, only 4 out of 10 patients were able to take their prescribed medical therapy for varieties of reasons, side effects, costs, so on and so forth. Well, cost may not be a factor, but side effects and non-compliance in general. 28%, there was a crossover to invasive over 4 years, which is not unexpected. We have seen that in previous data. And we'll longer follow favor invasive strategy, as we talked about how the graph has kind of crisscrossed because of reduction of spontaneous MIs. I think that would be very interesting. I think that has gotten a lot of our interventional colleagues excited about it. But again, we can't say that based upon the ischemia trial, as we know. So what have we learned from ischemia? In patients with stable CAD and moderate to severe ischemia with preserved LVEF, a routine invasive strategy compared with an initial conservative approach does not reduce mortality. A routine invasive strategy does reduce the occurrence of late MIs, although the cost of procedural MIs, as such, there is no long-term impact on total MI, cardiovascular death or MI, or protocol-defined MACE, death, MI, hospitalization for unstable angina, heart failure, resuscitated cardiac arrest. Patients with stable CAD and moderate to severe ischemia have a significant durable improvement in angina control and quality of life with an invasive strategy if they have angina daily, weekly, or monthly. Okay. So what are the questions now raised by ischemia? How should we diagnose stable ischemic heart disease? With stress imaging, exercise tolerance stress test, or coronary CTA? I would love to ask our imaging colleagues which is the best way to define that. I think stress testing is becoming less and less the favorite child. Do we need to rule out left main on everyone with at least moderate ischemia on a stress test? I think so. I think that's where the role of coronary CTA, and if you don't have the technology of a cath, can be very helpful. I think when to cath but when to revascularize are really two different questions. But again, oculostenotic reflexes do work in favoring early revascularization there. What is the mechanism for the reduction in spontaneous MIs in the invasive strategies? When we always have thought that a lot of those MIs after PCI are happening from non-stented lesions anyways. So then why are we seeing reduction of spontaneous MIs? Maybe that's a benefit of DAPT and statins and so on and so forth. We don't truly know. But then that should be the case in OMT as well. What is the long-term prognostic significance of procedural MI versus spontaneous MI? Nobody knows that answer today. And what is the effect of completeness or revascularization on outcomes? I think that is pretty clear. I think completeness improves long-term outcomes. We know that from several of our trials now, although this has not been addressed in ischemia so far. The publication is still pending. We are expecting it to come around this summer, and we shall see. So where are we with stable ischemic heart disease patients? What sort of workflow we should consider in those patients coming to our clinic? So obviously, if they don't have recent ACS or heart failure or reduced EF, you start with optimal medical therapy. There is no questions asked. Now, if a patient has low EF, I think they ought to at least get a cath or a CTA. But anyway, so you start with optimal medical therapy. But again, it's important to understand and rule out left main disease. If there is left main disease, again, usually by a CTA or a cath. If there is left main disease, then those patients should be revascularized. But if there is no left main disease, then you kind of try the optimal medical therapy and ask the patient, do you still have symptoms? If they still have symptoms, then we can talk about preferences and see what more we can do with medical therapy if there is any room. Because a lot of patients would adjust their lifestyle to correct their symptoms too. And there are more medications. But if there are no residual symptoms, the patient feels well, he or she is satisfied, then we can continue safely, based upon the primary endpoint, we can continue safely to pursue optimal medical therapy. There may be slightly more spontaneous MI, but it washes out compared to the procedural MIs, and hence, at least median follow-up of 3.3 years, that patient is statistically not at higher risk of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. I think it's very reassuring to a clinician, to a clinical cardiologist, to be able to say this to your patient. Because if they are unsatisfied and we have left main concerns or proximal high-risk anatomy, we do a cath, we revascularize, we try to approach a multidisciplinary heart team approach whether it leads to bypass or PCI. Okay. So, as I started off saying, I'm an invasive interventional cardiologist. Sorry, but my bias was obviously doing PCIs. So that's the patient. We fixed both the LAD and the RCA with atherectomy and drug-eluting stents. There goes my bias. Okay. So I hope you have enjoyed our discussion on the ischemia trial and this whole concept about when to revascularize, how do we pick our ideal patient, what we are able to tell our patient. I think that is what really was my focus today, to be able to empower you guys from the data we have to make a judgment call you can share with your patient with some degree of comfort and confidence. Now, we're going to quickly move on to our second segment of the CV Live, which is cases. Today I've selected one case, and I thought we will try to quickly go through that. This is a case where a 67-year-old male who presents for evaluation. He has a history of CAD, coronary artery bypass surgery more than 15 years ago. Remember that, more than 15 years ago, paroxysmal AFib. He had a cath done outside, which has found left main with diffuse calcified 90% stenosis, which bifurcates to LAD and circ. The LAD is totally occluded. After the first diagonal, the circ is totally occluded right at the ostial segment. RCA is codominant with total occlusion at the ostial segment. The lima is connected to the mid-distal LAD with no issues. Lima to LAD is great. Vein graft to RCA is gone. The vein graft to OM1 is healthy, is patent, but does have 30-40% stenosis. The vein graft to second OM has several degenerated disease segments. Ostial is 90%, there is 75% in the mid, and the anastomotic side is stenosed, and so on and so forth. So multiple lesions with degenerate looking graft. The LVDP is 25, or EF is 6 to 65%. He was referred here for a second opinion in regards to treatment of the vein graft to the circumflex artery. High risk anatomy, the vein grafts were shut down. So, well, why don't you go after that? PET testing did show large area of moderate to severe ischemia involving apical, abasal, inferior, infraseptal, mid, and segments. He has daily significant dystonia exertion, which is limiting his quality of life. He's already on multiple medications, including Crestor, Fenofibrate, Vascepa, Metformin, Lopressor 50, Plavix, Xarelto, Ranexa, Repatha, so on and so forth. So patient with a documented ischemia has a very degenerate OM2 graft with multitude of lesions. Well, what do we do with that? I mean, that's the question. So how do we, the patient was referred to me to fix the vein graft. Is that the right strategy when the vein graft is more than 10 years old? Here it's 15 years old. So let me just quickly look at you. So this is going to run by quickly, but you can see on the left, these are all caudal views. This is graft to OM1, this is graft to OM2, which has multitude of disease, and this was the initial target. So we took him to the cath lab and we take this shot, and you can actually see the left main and then the occlusion into the sarcosteum. But you can see there is OM1 graft, OM2 graft, and maybe we can consider another strategy. So to look up with another strategy, we did bilateral injections. We took this guide from the left main, and then we took a second catheter into the SVG to OM and did simultaneous injections, and see what you see. This is a shot. You suddenly realize the CTO is not that long. The CTO segment is actually very brief, probably very small. It looks very calcified. It is tough anatomy, but you can clearly see that it is not a very long CTO. Based upon that information, we decided to go after the native left main to the circumflex CTO. And this is just a very long fluoro image of us going through varieties of wires. But if I remember the last wire which successfully crossed, and we started with antegrated wire escalation technique. I think finding the right channel and poking in the right place was very key to us, and we were able to get the wire, I believe it was pilot 200, which allowed us to cross successfully through the lesion. So as you can see, we are very careful. We are not trying to push it too hard, almost trying to finagle it through. And here we go, boom. There's a point of success, and we are able to get the wire through the CTO. But remember, pilot 200 can go subintimal, and you would never know the end of it. So we always do a simultaneous injections, and you can clearly see that it is within the lumen of the circumflex artery. Once that is done, you bring in a balloon, and the rest is easy peasy. We finally basically put in a couple of stents, and there you go. That's the final result. And you can see the entire circumflex tree is lighted up. This is a nice case from our cath lab I wanted to share with you guys today, because I really believe that time has passed where we keep on going after degenerated vein grafts in the hope that that will be a successful strategy. It never is, because those vein grafts continue to degenerate. The patients are back in 6 months or 1 year. You're almost guaranteed of that. And I think with the current CTO techniques we have, I think more and more patients ought to be revascularized, going after their de novo native coronary arteries, because there we can apply the rules of restenosis. There we can apply the rule of cholesterol management and secondary risk optimization. Versus with vein graft, they remain highly unpredictable, and I think this is a better strategy. So that's what we ended up doing. Okay. I have to go to the next segment, but I believe we have a question that, let me see if we have time to address that. And the question says, is there an at-home stress test that one could try to identify risks and know if they should seek therapy? That's a very good question. A home stress test. I think we have often used 4 METs as a good way of assessing, for example, perioperative risk calculations, which somehow in my idea would equal to a flight of stairs. I think if you can climb 2 flights of stairs up and down, I think you probably would pass a stress test. But that still is not very scientific. I don't think we should rely fully on that. For our patients, we should reach out and make them understand their risk factors, whether it is family history or diabetes, dyslipidemia. And based upon that, I think the simple way to assess our own risk, our patient's risk, is to consider doing coronary calcium score. And if the calcium score is abnormal, then certainly further testing ought to be performed. But I would probably recommend a professional opinion at this point from somebody who can does even a treadmill tolerance stress test or even an imaging, depending on the findings. So I hope that helps you answer that question. Now, I would like to go to our next segment, and the next segment is a quiz. Okay, I hope you guys saw it. I wanted you to see that and tell me, hopefully we'll reconnect in our next talk, which will be in about a month's time, to what was the finding on that. There's a very interesting collateral vessel, and I want you all to tell me the name, and you'll get a brownie point. So let me see if I can replay that one more time. And one more time. You can see the distal RCA filling. All I need you guys to tell me is the answer to this quiz as to what is that collateral vessel called and where is it coming from. Okay, we have one more question. And the question is, what is the indication of coronary CT scan before coronary artery bypass surgery? I think that's a wonderful question. So obviously we would assume that this patient has gotten a cardiac cath. But a lot of times cardiac cath is a luminogram. So it does not tell you entirely what is going on in the vessel wall. I recently had a very young lady who went through coronary artery bypass surgery. There was ostial LED lesion, and we sent her for bypass surgery. And the surgeon, she was a dialysis patient, the surgeon basically called me and said he had a hell of a time trying to get a lima sewn into the mid distal LED because it was just supremely calcified. And I look at the angiogram, and it just doesn't look terribly bad. I think a coronary CTA can be priceless in patients like this. I think there are some patients where if they have a CTO and you are sending those patients for bypass surgery, often the distal vessel is so underfilled that it is hard for a surgeon to actually determine if it is suitable for grafting. And I think that would be another application. So one is obviously understand better the vessel wall and the amount of calcification especially. And the second is better assess the diameter of the distal vessel, the landing zone where they can actually sew in their bypass graft. I think besides that, sometimes knowing the status of their aorta is also very helpful. I think a lot of times surgeons would come back after a CT and say, oh my goodness, that's a porcelain ascending aorta, and that would be impossible to bypass into. Why don't you see if you can consider doing a PCI in those patients? So there is definitely a role prior to bypass surgery in those patients who already had a cardiac cath. I think there's definitely a role. Okay, we have one more question. How to manage non-revascularized segments after incomplete bypass surgery? Well, it does not happen a whole lot because our surgeons are so good, and they obviously will not accept a patient where they would feel like they're going to go into an incomplete revascularization. But that being said, you got to follow those patients clinically. I mean, there are patients where a bypass surgery has been recommended, and they go through bypass, they put in a nice lima, they put in a graft to vein, and a lot of times they'll come back and tell, oh my goodness, that distal RC and the PDA looked horrendous. There was nothing we could plug into that. So a lot of those patients, I would actually follow them medically for a while, see how they are doing, see how their symptoms are, and maybe consider doing a stress test. Surprisingly, most of them do pretty well. I think the lima to LAD is a game changer. If a patient has a lima, you probably are rest assured that your patient, all said and done, is going to do really well. It's hard to have a major cardiac event when you have a lima to LAD patient. But nonetheless, with the technology we have today, I think it's fairly possible in the vast majority of patients where we can revascularize. Whether it's extensive calcium, we can burr, we can lithoplasty. Whether it is CTO, we can use CTO techniques and go after that RCA, for example. So those patients are tremendous options, and I think they ought to be rediscussed with their cardiologist. Because at the end of the day, as cardiologists or as surgeons, our goal is to do complete revascularization, because nothing beats that. And we know that from our scientific data. So I think we should consider doing that. Now, that being said and done, there will be some patients who have really no options to revascularize. Well, as we speak, and maybe I'll join my colleague Dr. McIlroy, who is a cardiac surgeon, and we are going to start a clinical trials in genetic injections of genetic material to those areas of the heart which are still low on oxygen or ischemic. But there is no option to revascularize those patients. So keep your eyes and ears open. Hopefully in the next 2-3 months, we will be able to talk about that as a clinical trial. But there are options. But again, I think it is important to discuss, to review those angiograms who are with aggressive interventionalists. Okay, so that being said, I think we have reached our conclusion of this episode 1. I hope that you guys have enjoyed this. I hope you have learned a few things. Remember to answer that quiz. We're going to catch up on that next time. And yes, you will get a brownie point. But otherwise, thank you so much. I'm glad we are all learning together in this digital age, in this age of COVID-19. I hope you all stay safe and healthy. Thank you again.